Efficacy and Safety of Endoscopic Radiofrequency Ablation for Unresectable Extrahepatic Cholangiocarcinoma, a Randomized Trial. Introduction. Extrahepatic cholangiocarcinoma is a malignant tumor with an increasing incidence, accounting for approximately 3% of all malignant tumors of the digestive tract. Extrahepatic cholangiocarcinoma is divided into perihilar and distal extrahepatic cholangiocarcinoma at the level of the cystic duct. The only opportunity for long-term survival of patients with extrahepatic cholangiocarcinoma remains surgical resection with negative pathological margins. However, because of its special anatomical location and occult onset, early diagnosis of extrahepatic cholangiocarcinoma is difficult, and thus surgical resectability is only 20% to 30%. For patients with unresectable extrahepatic cholangiocarcinoma, endoscopic placement of biliary stents to reduce or relieve jaundice is the main palliative treatment, but does not extend patient survival, as the average survival time of these patients is only 6 to 8 months from diagnosis. Compared with distant cholangiocarcinoma, patients with Bismuth type 3 and 4 hilar cholangiocarcinoma benefit less from endoscopic stent placement and have a worse prognosis. As the tumor continues to grow, reobstruction of the biliary stent can cause recurrent jaundice or recurrent cholangitis, as well as liver, retroperitoneal, and other systemic distant metastases. Therefore, active control of tumor growth is key to prolonging patient survival and stent patency. RFA is an effective local ablative therapy that has been used extensively in many solid organ malignancies, especially in hepatocellular carcinoma. The working principle of RFA is the emission of heat energy via a bipolar probe by using high-frequency alternating current, which in turn causes localized tissue necrosis. Percutaneous RFA treatment can lead to radical cure in stage A to C liver cancer for tumors less than 3 centimeters in diameter. A meta-analysis also showed that RFA can significantly improve survival time in patients with unresectable intrahepatic cholangiocarcinoma. RFA has also been recently applied to treat unresectable malignant extrahepatic biliary obstruction. In 2011, Steele et al. First reported on 22 cases of advanced biliary obstruction, 16 cases of pancreatic cancer, and 6 cases of cholangiocarcinoma, treated with endoscopic bile duct RFA using the Haibin Endo-HPV bipolar radiofrequency electrode. Emcision, London, UK. In all, 21 cases were successful, yielding a technical success rate of 95.5%. Because of its simplicity and safety, the clinical applications of endoscopic RFA in the treatment of malignant biliary obstruction have expanded. Preliminary results show that RFA can significantly prolong stent patency, which may also be beneficial for improving patient survival. However, the vast majority of studies reported to date have been retrospective case series of patients with malignant biliary obstruction treated with RFA, and very few have studied extrahepatic cholangiocarcinoma only. Therefore, whether RFA prolongs survival time and stent patency in patients with extrahepatic cholangiocarcinoma remains unknown, and further research is needed in this area. The authors conducted a prospectively randomized and controlled study to investigate the effect of endoscopic RFA using a Haibin Endo-HPV bipolar radiofrequency electrode combined with stent implantation on survival and stent patency. The authors also evaluated the incidence of adverse events in patients with extrahepatic cholangiocarcinoma. Background. Endoscopic placement of biliary stents to relieve jaundice is the main palliative treatment for unresectable extrahepatic cholangiocarcinoma. Endoscopic biliary radiofrequency ablation, RFA, has been reported to prolong stent patency, which may be beneficial in improving patient survival. However, available evidence is still insufficient, as most reported studies are retrospective case series. The aim of this study was to explore the clinical effect and safety of RFA in patients with unresectable extrahepatic cholangiocarcinoma. Methods. 65 patients with unresectable extrahepatic cholangiocarcinoma, except Bismuth type 3 and 4 hilar cholangiocarcinoma, were enrolled and randomly underwent either RFA combined with biliary stenting, RFA plus stent group N equal 32, or biliary stent-only group N equal 33. Overall survival time, stent patency period, and postoperative adverse events were recorded. Results. In the 21-month follow-up period, the overall mean survival time was significantly longer in the RFA plus stent group than in the stent-only group. 13.2 plus or minus 0.6 versus 8.3 plus or minus 0.5 months, p less than 0.001. The mean stent patency period of the RFA plus stent group was also significantly longer than that of the stent-only group, 6.8 versus 3.4 months, p equals 0.02. There was no significant difference in the incidence of postoperative adverse events between the two groups, 6.3%, 2 of 32, versus 9.1%, 3 of 33, p equals 0.67. Conclusion: endoscopic RFA combined with stenting can significantly prolong survival and the stent patency period without increasing the incidence of adverse events in patients with extrahepatic cholangiocarcinoma, except bismuth type 3 and 4 hilar cholangiocarcinoma. This approach can be considered as a safe and effective palliative treatment for these patients.